Namaskar. Today, I have decided to share my thoughts about prenatal diagnosis and termination of pregnancies. This is the right time to think about the various issues related to the prenatal diagnosis, which mainly revolves around the fetus and the family. We are the ones who provide the technique of prenatal diagnosis and are also responsible for providing the correct information and issues related to the prenatal diagnosis so that the family can take appropriate correct decisions for their family. I, with a pediatric background and doing genetic counseling and prenatal diagnosis in addition to the evaluation of proband and then doing laboratory-based diagnosis for last 3 decades, I have the whole 360-degree view of the prenatal diagnosis procedure and feel that my views are important to be shared with the lay persons as well as the doctors. As you know, that prenatal diagnosis is mainly for prevention of genetic disorders, because at present the disorders which can be treated after prenatal diagnosis are very, very few. So mainly if the disorder which is prenatally detected is severe enough and the family wishes to avoid birth of such a child with serious disorder, untreatable disorder, or disorder which is very difficult to treat, then they can opt for termination of pregnancy. So basically it is the question of life and death of a fetus. So one side we always say that prevention is better than cure. But here it is not the prevention of the disease only, but prevention of the birth of a child with the disease. That means termination of pregnancy. Hence, the issues about prenatal diagnosis and the prevention by prenatal diagnosis have to be really discussed and thought with a great sensitivity. The two important points which I am going to discuss today is prenatal diagnosis and termination of pregnancy justified for treatable disorders? And secondly, whether screening for all rare genetic disorders should be offered to the persons or families with very, very low risk of such background risk of these disorders. So one would feel that if it is a treatable disorder, then the prenatal diagnosis should not be offered. But we will have to look at the treatments seriously. And the other point which I want to talk briefly is about termination of pregnancy. The medical termination of pregnancy is legal in India as well as in many other countries, but it can never be considered a ethically or emotionally right thing. This is because the fetus, even in the womb, is life, and then there may be debates about when does the fetus become really gets identity, and whether the fetus has a right to survive of his own, or whether mother's wishes can overrule the fetus' right. So all these issues are very complex, and there are different people with very strong views on either side. But we know in India, termination of pregnancy is allowed before 20 weeks, and now it is extended to 24 weeks. So we take this as a really gestation where, because the fetus after that becomes survivable, we can consider that these are the strict points before which the fetus has less rights, and after that particular gestation age, the fetal rights become more important. Coming to the prenatal diagnosis of many malformations and disorders, I have talked about uncertainties in prenatal diagnosis many a times, and these are the various treatable disorders. And here, mainly when these prenatal diagnoses for these disorders come into question, because the family has a child or an affected individual with any of these disorders. And then the question is whether the second fetus, should we offer prenatal diagnosis and then terminate the pregnancy if the fetus is really affected with the disorder. So we had many experiences. A very poor family where the first child was detected to be biotinidase deficiency, and then on treatment, because the baby was detected by newborn screening, the next time they did not want prenatal diagnosis and they wanted only neonatal screening, and then again the second child was affected and they started treatment timely. So in these situations, as I say, that our important role is to confirm the diagnosis. Like in this pedigree, the 10-year-old child who had cochlear implant was diagnosed to have a congenital deafness. Here, the most important question is whether it's an isolated deafness or a part of a serious disorder like JLN syndrome, where there can be a sudden death because of arrhythmia, or Usher syndrome, where the child can have associated retinitis pigmentosa, giving rise to blindness. So if it is isolated, then we know the prognosis is very good and the child can be treated. For other disorders, which I said, the treatment can be very easy, like in case of surgery for cleft lip or splenectomy for hereditary spherocytosis. But then the treatment for gene therapy, now it is available. Treatment by gene therapy is available for spinal muscular atrophy, but we know it's very costly and we also don't know the long-term effects. Then the lifelong diet for PKU or BMT for thalassemia, we can consider they are treatable, but whether they are easily treatable or not, and if there is no donor for the BMT for thalassemia major, and then what should be done. Even the treatment with hypertransfusion for thalassemia major is nowadays, it's funded by government in Lucknow and Uttar Pradesh and many other states. And the patients are like, now they are not children. We have patients as old as 40 years and doing very successful life, education, jobs, as well as businesses. So basically, these treatments, they are available, and these challenges are taken by the families and treatments are done. The children are treated and patients are doing very well. But the severity of the disease, cost of treatment, availability, then sometimes the burden of lifelong therapy, all these things vary from disease to disease. Many families with autosomal dominant polycystic kidney disease are not bothered about recurrences, and they usually do not go ahead with prenatal diagnosis. So we can see whether the family wants prenatal diagnosis or not will depend on their experience about the disease and their outcome of the individual in their family. So for many of these disorders, if there is a previous child with a disorder, we can provide them non-directive counseling, and many of the families may want to prevent recurrence. And then usually they will go ahead with prenatal diagnosis, usually early, before 20 weeks. And then termination of such disorders may be justified by us as well as the family. But very easily treatable disorders like isolated deafness and cleft lip, and very late onset disorders where we know that then the individual might live a good life till then, or even new treatments may become available, we should not encourage, or we should discourage prenatal diagnosis for such late onset disorders and very easily treatable disorders. So this I say that otherwise we usually say non-directive counseling, but as a part of, as important part of the society, being knowledgeable in this area, we have to see that the society also follows good ethics principles, and from that angle, we have to really give, though we want to give the importance to the parents' decision about non-directive counseling, but I think for very easily treatable disorders, families may not want termination of pregnancy, and we should not encourage them also. So basically, as we saw, that whether to go ahead for termination for particular disorder or not, it's very not always black and white. Same way, the ultrasonography, which is done for all now pregnancies, and it's very important because that is useful to improve the outcome of the pregnancy. There some malformations or some ultrasonographic variations are detected in the fetus, and then the question comes whether to terminate or not to terminate. Here the main problem is that with improved technology, the ultrasonographic diagnosis is very easy, but we will not many times know whether there is the cleft lip which is isolated, or whether the talipoequinovarus is isolated, or whether it's a part of a serious disorder associated with, say, neuromuscular abnormalities or associated with cognitive dysfunction. So these various, all of you know that the outcome of these various ultrasonographic findings are very variable, marked from almost normal outcome to severe disability. And with invasive testing, we can always offer them genetic diagnosis as much as possible. And if there are no abnormalities detected on microarray or other investigations, then probably we would say that the residual risk of serious problem is very less, and then the families may continue, or probably should continue, the fetuses with such malformations or ultrasonographic abnormalities. Of course, the uncertainty is always there, and then here the gestation age at diagnosis is very important. Many of these abnormalities, especially aplasia of corpus callosum or microcephaly, they are identified in the later part of the third trimester. And there I feel that even if there is some risk of a small risk that the outcome may not be exactly or totally normal, but then because the fetus has crossed the gestation age limit for termination, we need to advise the family that because there is a very good chance that the fetus or the baby could be normal, and then they should be encouraged to continue the pregnancy. The important disorder which became very famous because of court cases is congenital heart block. Many of them are detected in later part of pregnancy, but we know that the outcome is good if the fetus does not develop heart drops, and it can be treated by pacemaker during neonatal period. In fact, some mothers have been identified congenital heart block during pregnancy, indicating that some of them lead normal life even without treatment. So naturally, if such disorders are detected during fetal life, the families need to know that they can lead a normal life and can be treated after birth. So we tried to make a questionnaire-based survey long ago, even before the gestation age of termination was not extended to 24 weeks. And we tried to get people's view, laypersons, by telling them what is a Down syndrome, what is anencephaly, meningocele, and ask them whether termination after 20 weeks or 28 weeks is allowed. So, or should be allowed. So here you can see that for serious disorders like anencephaly, where they are lethal, then probably many people felt that it can be terminated even after 28 weeks. But as the outcome becomes is better, like left lip or Down syndrome, many people felt that after 28 weeks termination should not be allowed or is not justified. Similar questions were also asked to clinicians, and clinicians also showed the similar trend that anencephaly and severe meningomyelocele, many of them feel that they can be terminated at any gestation, while congenital heart block, VSD, and cleft lip, most of the people felt that very few people that they should be terminated at any gestation, that means after 24 weeks. So these type of society's views are very positive, and they do not, most of the people do not feel like termination should be done for all these milder disorders at any gestation. And but sometimes our personal experience is that in India, because MTP has been legal for many years, many families just have very liberal views towards termination, and they feel that termination for very flimsy reasons. Many people undergo terminations. So we have to see that society is very sensitive toward the decision of termination and should consider various these views about outcome before opting for termination of any prenatally diagnosed fetus. So these decisions are very challenging, and depending on what is the malformation, whether it's a genetic etiology, what is the uncertainty of the outcome, and so many other things have to be considered. The decisions are very challenging. Counseling is very challenging. But for isolated mild malformations, I think people will not do termination, and we should discourage them for doing termination. And again, summarizing what I said previously, that if there is a previous experience with a disease in the family, then the non-directive counseling should be done, and early prenatal diagnosis should be offered for these disorders. So naturally, for which disorder to go ahead with termination and do prenatal diagnosis would be parents' decision. After 24 weeks, the law says that the committees, local committees should make decisions, but we have to really, many of us are members of this society, we have to see that it's not only what would be the outcome of that disorder, but basically whether the child will survive after birth or not. So basically, most important point to consider is that if the fetus is unlikely to survive after birth, or especially during infancy, then there's such severe disorders which can be lethal during neonatal period can be justified terminations after 24 weeks. So these include lethal skeletal dysplasias, anencephaly, and hair drops, etc. But I would again say that those disorders where the possibility of a poor outcome may be there, but the diagnosis is made after 24 weeks, then probably all these should be treated as if we would make decisions for a baby after birth, if a diagnosis is made after birth. So I will give this example of a closed spina bifida diagnosed prenatally at 28 weeks, and then they continued, and at 1 year of age, the baby underwent surgery without any neurological deficit. So any abnormality detected does not always mean that prognosis is poor, but sometimes a doctor couple where the prenatal diagnosis was done during before 20 weeks of gestation, and for such diastomatomalia, which usually does not lead to any neurological deficit, and the spina bifida was closed, they opted for termination. So these sometimes such views can be different, but I think more important is whether the fetus is less than 24 weeks or more than 24 weeks. So improved imaging, NIPS and NGS, these have opened up more uncertainties, and what the dilemmas whether to terminate or not terminate, they have become much more difficult in this era. So I will briefly talk about these two issues. One is NIPS, so non-invasive prenatal screening. It's very important and very useful, and it's a technologically marvel. So maybe trisomy 21, those who want to screen for trisomy 21 because it's the commonest disorder associated with intellectual disability. And then this NIPS avoids the invasive testing, as well as it's much more sensitive. So this is a very good, but for trisomy 21. But many times all these companies are offering NIPS for, in addition, sex chromosomal abnormalities. And that poses a lot of dilemma. Many XXX, XYY, there are no phenotypic abnormalities. And even for Turner syndrome or Klinefelter syndrome, they usually do not have any intellectual disability. and now reproduction by artificial reproductive techniques is possible. So why to screen for them? By chance, if they are detected by during amniocentesis, we encourage them that they should not be terminated. But this, by offering screening for sex chromosomal anomalies, we are telling them that these can be diagnosed. So I think non-invasive prenatal screening should not include sex chromosomal abnormalities. Same for the rare autosomal trisomies and microdeletions, so-called common microdeletion syndromes like 22q microdeletion. This is because these are very rare, their positive predictive value is less, and many of the families unnecessarily have to pose the dilemma, anxiety, as well as undergo invasive testing. And secondly, some of them like 22q microdeletion, many of them have so mild phenotype. You might have seen many parents of these children having subtle phenotype but no handicap. And by doing such type of antenatal screening, we may be terminating many fetuses who otherwise are probably absolutely or reasonably normal, but just because they have genetic deletion and then they are terminated. So those without cardiac anomalies and without any ultrasonographic anomalies, if you do just population-based screening, many of the 22 microdeletions who otherwise normally would lead long life would be terminated. And I think this is the most important message I want to tell. Whether it is carrier screening by NGS or very such type of microdeletion syndromes, where we don't know that what would be the exact phenotype, but just because it is a genetic abnormality seen in individuals with serious disorders or disabilities, we would terminate, the families would terminate such on such prenatal diagnosis. And that I think is a really very, very sensitive issue, because we know that unless the fetus should not be terminated unless we are 100% sure that the fetus is going to have some serious problem. But by doing such type of screening for disorders where there is a very different phenotypes and the phenotype may be normal in many, we would probably terminating many fetuses without who would not have serious handicap. Similarly, carrier screening by NGS. Now we know that we can screen all pregnant women or all couples before planning pregnancy for serious recessive disorders. And then this is like very easy. So now that everybody feels that they have right to screen for all genetic disorders, and doctors feel or scientists feel that we can assure the family that many of these disorders have been screened and can be ruled out, or if they are found to be carrier of such serious disorder, then the prenatal diagnosis can be offered. But how and who decides which disorders to be screened? Now hemophilia has become very good, very easily treatable disorder. The lives of hemophilia patients are absolutely normal with long-acting factors and other drugs. Spinal muscular atrophy has become treatable. Then some other disorders, like if you identify mutations in the dystrophin gene, and then we know whether the child would develop BMD or DMD, we would not know. And for sure, similarly, even those disorders like metachromatic leukodystrophy, Tay-Sachs disease, many of them have late onset variants. And so when we only identified a pathogenic or likely pathogenic variant for these so-called serious disorders, in a families where there was no child affected with metachromatic leukodystrophy or Tay-Sachs disease or Krabbe, we would not know what will be the phenotype of that particular fetus who has biallelic mutation in that family. So some of them even may be normal, because when we say that we will only select likely pathogenic variants for prenatal diagnosis, so some of the likely pathogenic variants probably may not be harmful, and hence we might be terminating fetuses who have the variant but may not later on develop disease. Then late onset variants, even Krabbe disease, the late onset variants as presenting as late as 40 years have been identified. So for families without any previously affected child, such type of carrier screening probably you would lead to identification of many variants which may be mild or may not be harmful or may be present in the normal individuals. And I think the outcome we do not know, unless many of them treatments will keep on coming after next years, and so for some of them treatment is already available. So when we are offering, we may feel that we tell the families to decide, but families cannot understand the variability of these diseases. They cannot understand the phenotypes of 5,000 diseases. They cannot understand that each disease may have different severity in different individuals and different families. So while offering, what to offer is our decision based on our knowledge and wisdom. We should not let it tell the families that we can see, we can technically test all of them, but we do not know that we at present we are far away from the interpretation of variants. So basically, I again want to stress that carrier screening by NGS for those family members who do not have any patient or child with or never had a child or a fetus with possibly genetic disorder should not be done. So, again, the reasons I want to tell is there is no genotype-phenotype correlation. Many Gaucher disease patients may present in 40s, then some likely pathogenic variants may not be pathogenic at all, as we know. And we know how difficult it is to interpret a variant even when we identify and see it in a patient. Even if the patient is available to us for investigation, evaluation, many times our variant interpretation is a great challenge. Then how do you use those variants in a individual who does not have any signs and symptoms, and just screen carriers and based on that terminate fetuses? I really don't understand. So at present, we really don't have any idea how many normal babies would be labeled affected in this process and would be terminated. And we also do not have how many affected babies will be missed. We tell them that by doing NGS, we do not guarantee a normal baby. But in India, about half of our causative variants in Indian patients are novel. So at present, we do not have any database of disease-causing variants in India. Then why are we offering carrier screening by NGS when we don't know which are the normal variants, we do not know which are the pathogenic? So, and we also do not have whether society wants and these or not. There are no research on the societal mindset, psychosocial issues, what the society wants and whether they have understood these issues or not. Only thing is that in simplistic terms, they feel that this type of testing, probably normal baby will be born and most of the diseases can be avoided. So the such simplistic explanation probably is very luring, and many clinicians who offer these tests, they are also not at all aware about the lack of genotype-phenotype correlations. They are not aware about the phenotypes, like how Down syndrome children work and how much their outcome, how much can they contribute to the society. Similarly, they may not be aware of such late variants of all these diseases which we consider serious, like Tay-Sachs or metachromatic leukodystrophy. So just such type of offering, such type of carrier screening by NGS at present, not only in India, any worldwide, I think it is a too early thing to do, and probably we are doing misguiding the society. I have already said that we do not have any databases, and interpretation of variant is very challenging. So it is too early to offer screening for general population by using NGS for all recessive serious disorder. And we need to conduct research on the psychosocial aspects of such challenging prenatal situation, whether the family is what they think. And in research settings, you need to evaluate such type of protocols if you want to do screening, carrier screening by NGS, and to find out what the family would like, whether they would like in an attempt to really getting a normal baby. Are they prepared that sometimes Some normal babies may be terminated and they may not have a pleasure of childbirth or see a child growing, or somebody develops DMD at 5 years, but still the child is with the parents and lead happy moments with them till 10, 15 years of age. They see the child growing and there's a pleasure of bringing up child. So do they want to give away everything just that and terminate first child with DMD by just screening? And also some of those DMD mutations may be really PMD causing also. So the advanced terminology has sort of giving, it's very technologically marvel, the imaging as well as the NGS bed technology. But it's also giving the promise of perfect baby. And this promise is with probably at present little over ambitious, and we are sometimes becoming overconfident doctors and technology, and we are creating new uncertainties for the families. Families also feel that they are increased control over the baby. They have right to have normal baby, and it means that if any fault is detected, then they have right to terminate. And many people that feel that termination can be done at any age, any gestation age. Of course, there is a lot of variability, but such type of trend which is developing in the society, I feel that it is the time that we all sit together, and the geneticists who have seen so many patients with these disorders, we have seen mild patients, we have seen late onset patients, we have faced genotype phenotype correlation in the NGS based testing in various families just for carrier screening or in the patient. So we all need to educate those who are involved in the antenatal care and maybe sometimes fetal care about the intricacies of genetics and what at present genetics does not know, and hence such type of uncertainties we cannot put in the court of the family under the disguise of non-directive counseling. We have to know what is the possibilities and then only offer those tests, so that the families can take the correct decision, and they will not be able to make non-directive counseling if they don't know what 5,000 genetic disorders. So the families may feel that we want to take care of everything and see that the baby is normal, but we know that there is no risk situation. Always there are different types of risk, and what type of precautions can be done, this is the difference. So for healthy baby, I would say we have to see that we have to decide what type of screening we have to offer, and we have to really decide that what screening should not be offered, and that should be a very definite thing, that we cannot lead to the family that the technique is available and if you want you go ahead with the screening, and such type of non-directive counseling for screening is, I think, not really possible. So again, NIPS for rare autosomal trisomy is 22 microdeletions, all those things probably, and sex chromosomal anomalies should not be offered as a society, as a medical doctors and those who are involved in the fetal care. Then second, again, I want to highlight many abnormalities like holoprosencephaly are detected in the late third trimester. And here again, though the law says after 24 weeks, the committee can decide and give option of for termination, but this baby will be born alive. And we have seen that when the prognosis is poor, still the family wants to give the birth to the baby, take care of the baby as much as possible. And this type of maternal love sometimes is very, very, we have to see that these issues are considered, and not only the outcome, that if the baby is not going to survive, just terminate. That type of knee-jerk reaction should be avoided by anybody who is working with the fetus. So same thing, as I said, all these issues, so complete heart block, severe ventriculomegaly, if they are detected in the after 24 weeks, the decision should be as what we would take that when these diseases are diagnosed in the newborn. In the newborn, if you diagnose holoprosencephaly, you don't kill the baby. You take care of as much as possible, and same should be done if it's detected in the fetal life after 24 weeks. So summary and conclusions, I would like to again highlight that if the family has first child with the or other individual with a serious disorder, genetic disorders, it should be properly investigated, preferably pre-pregnancy, and the parents' decision to go ahead whether they would like to go ahead with prenatal diagnosis and termination, and we should be preferably done at the as early as possible. Similarly, this can be only done if every obstetrician takes care, takes 3-generation pedigree, draws 3-generation pedigree in first visit, antenatal visit, or if their families are encouraged for pre-pregnancy genetic clinics, and then these families will be identified. So for screening low-risk population, again, 3-generation pedigree, which is the simplest and less no cost test, should be done for all families. And then if there is an affected child, it can be investigated, genetic counseling be provided. If the child is not alive, then the parents may be investigated for carrier status of that particular phenotype which was present in that family. For general population screening, in India, the beta thalassemia and thalassemia are quite common. These are quite serious disorders. And though the treatments are available, the treatments are also challenging. So these may be offered to the families, low-risk families without family history of these disorders. But they should know that some of those beta thalassemia carrier couple the child may have a milder type of thalassemia, non-transfusion dependent thalassemia, and even some cases with spinal muscular atrophy, where both the alleles are mutated, they may be mild type 3 or type 4 who usually manifest in later part of the life. So they have to know that some of these cases we will not be able to differentiate from serious type of spinal muscular atrophy. So again, to stress, NIPS, no for rare autosomal trisomies, no for sex chromosomal anomalies, and no for microdeletion syndrome. So carrier screening by NGS without any family history of genetic disorders, it should not be offered. And if there is family history of a genetic disorder and proband is not alive, then probably we can go ahead and tell the family about carrier screening by NGS, and also explain them limitations, complexities, dilemmas which may pose in front of them by NGS-based testing. Consanguineous couples, we should provide the information that there may be slightly increased risk of recessive disorders. So it's not that all consanguineous families have very high risk of recessive disorders. There are many families consanguineously married in the general population who don't come to have you because they have normal children. In India, because of inbreeding, many of the such families who are non-consanguineous also may have similar background risk. So what is important even for consanguineous families is 3-generation pedigree and evaluation of a baby or child or individual who has such serious disorder. And then they may be provided information about carrier screening by NGS, but the complexities are there, and these genetic counseling should be done by experts or in the area. Many people feel that pre-implantation genetic diagnosis is a simple way to avoid such type of families who are at risk of genetic disorders, but not only the financial cost, but pre-implantation genetic diagnosis, the percentage outcome is less, and then also there is increased risk of other birth defects, prematurity, and many other things. So the family needs to know that pre-implantation genetic diagnosis itself has many other issues and risk involved. So lastly, I would end with this thought-provoking article and a book. So now we know that, as I said, there are many genetic variants have late onset diseases. And why this happens? Because there may be many modifier genes. Fabry disease, somebody may develop cardiomyopathy, somebody may develop renal failure in 40s or 50s. So why does it happen? Somebody may not have any symptoms at all. So now we have realized, and everybody has been previously also knowing, that sometimes the mutations are very necessary for development of disease, but not sufficient. And they need to have some other genetic and non-genetic environmental factors to precipitate the symptoms of the disease. So now these genetically transitional diseases, a new concept is arising, and this is an interesting article by Greg Gibson you need to read to understand that why I'm saying that, not that every variant you identify in the couple is likely to be pathogenic and will lead to serious disease in the fetus. Secondly, this is another book, The End of Genetics by David B. Goldstein, and he is a scientist who has identified genes for many rare disorders. And he feels that the genetic technologies are improving fast, so diagnosis is improving, but the pace of developing treatments is relatively slower. So basically what is happening, that the parents feel that these are serious disorders, and even if they are extremely rare, they would like to go ahead and go for this type of screening and prenatal diagnosis, and they want, the families feel that they have direct control over the genomes of the children, and this is sometimes I feel is really frightening. So after 3 decades of prenatal diagnosis, it's time to think whether how much we offer screening to the low risk population who do not have any idea about or any experience of these rare genetic disorders. And this termination of 24 weeks should be restricted to only lethal disorders, and not only any disorder which manifests little later part of the pregnancy. Why I feel this? Because what is happening, the parents desire to have perfect child, which is absolutely correct. And this is very, they will have, any parent will have this emotional reaction. And the technology is giving hope that they have control over the genomes and phenomes of the baby in the womb. And we diagnosticians feel that we are overconfident that we can diagnose these disorders in the baby. So altogether probably is making holes in the fabric of ethics of the society, and probably also damaging some maternal love for the child. So we have to really sit together and think about it when you talk to the patient, what you offer to the patients, and don't get carried away by what the developed countries are doing or what the laboratories are offering, and what you feel that scientists are telling that these all can be done. So they are not telling you what are the limitations. So all these things need intense communication. Like I wanted to communicate with you doctors, but also we have to communicate with the patients and families. And this type of complicated information needs a high level of communication skill and lot of patience. Thank you very much.